Good morning, everyone. Thank you for joining us for this week's Virtual Journal Club. My name is JP Britton, endocrinologist at Mayo Clinic and a co-host of these virtual events. This morning, I have the honor to introduce a dear colleague and friend, Dr. Haixia Guan. Dr. Guan is going to be presenting today management of thyroid cancer and thyroid nodules in China. Dr. Wang graduated from China Medical University in 2003, then completed her internal medicine residency and fellowship in endocrinology at the First Hospital of China Medical University in Chang'an. Then Dr. Wang came to the United States for additional research training at Johns Hopkins, as well as the Brigham Women's Hospital. And in between 2003 and 2020, Dr. Wang has served as an endocrinologist in the Department of Endocrinology and Metabolism, the First Hospital of China Medical University. Currently, she is a professor and deputy director of the Department of Endocrinology in Guangdong Provincial People's Hospital in Guangzhou. She's a member of the American Endocrine Society, American Thyroid Association, and Asia-Oceania Thyroid Association, as well as the editorial board member of the Thyroid, Clinical Thyroidology, Journal of Clinical Endocrinology and Metabolism, and Endocrine. Dr. Wang's research interest includes thyroid disorders, effects of trace elements and vitamins in human health outcomes, endocrine disorders in pregnancy, and tumor-related endocrine disorders. She has had more than 100 publications, including peer-reviewed articles in New England Journal of Medicine, JAMA Network Open, Journal of Clinical Endocrinology and Metabolism, thyroid and cancer. She has been involved in several important Chinese guidelines for the management of thyroid diseases, clinical guidelines for the management of thyroid nodules, and differentiated thyroid cancer, as well as clinical guidelines for radioactive iodine treatment in Graves' disease. In view of these achievements, she was the recipient of the Excellent Young Investigator Award from the Feng Yin Dong Education Foundation and Ministry of Education in China. So with that, I will turn it over to you, Dr. Wang. Thank you very much for accepting our invitation. Well, in the meantime, I extend an invitation to the audience for the Congress. The World Congress of Thyroid Cancer is virtual. The second session happens this Sunday, October 16, 2021. If you want more information about this Congress, then you can see the links there.
Can you hear me?
Yes, now we can hear you.
Can you hear me right now? Okay, so right now I'm going to use this keep this cell phone on, and I'm going to go through my slides, right?
Yes, that will work. So you will do it through your phone, the audio, and we can still pass your slides. Yes.
Okay. Finally, sorry. Okay, everyone. Many thanks for the invitation, and thank you, Dr. Brito, for the kind introduction. And good morning, everyone. It's my great honor to present the virtual meeting. Today, my topic is the management of thyroid cancer and thyroid nodules in China. I'm going to disclose. Objectives of my presentation today include to introduce some epidemiological data of thyroid nodules. So can you hear me right now?
Yes, I can hear you. I still see the slide about disclosures, though. I don't see, that's the slide that we're looking at.
So can you give me the sharing the slide sign again? Okay.
Okay, yes, now, yes, perfect. Now we're seeing the objectives.
I think here, and okay.
Let's continue. Okay.
So objectives of my presentation today include to introduce some epidemiological data about
Underserved
cancer in China, to talk about the controversies on
cancer in China.
nodules are evaluated one by one. I'm sorry, Debbie. I can hear the voice from your
Yes, the audio is not.
The audience can hear me.
Yeah,
Yeah.
we cannot hear you that well. We hear a little bit of Well, it sounds like an echo or just two people talking at the same time.
Objectives, okay. So can you see my camera? Still, I can hear. Can you see my face on the screen or just my slide?
Your slide is actually good. I can see the full screen of your presentation mode. So the slide,
Okay.
unless, yes, right now it's in the objective slide and we can see it very well.
Okay, let me continue. So my objectives of this study, of this presentation, and is going to introduce some epidemiological data of thyroid nodules and thyroid cancer in China, to talk about controversies on screening thyroid cancer in China, to present how the thyroid nodules are evaluated in China, and to show how thyroid nodules and thyroid cancer are managed in China. So in my presentation, I will try to focus on the difference between the United States and China. Okay, let's start with the epidemiological data in China. The most recent prevalence number of the nodule was from the Tide study. This is a nationwide investigation, and the results have been published in the journal Thyroid last year. The median urinary iodine levels and the prevalence of goiter in both adults and children indicate that the current iodine nutrition in China is adequate. Shown by this study, the prevalence of thyroid nodule, which was detected by ultrasound, is 20.4%. The prevalence is higher in females than in males and increases with age. Regarding the incidence of thyroid cancer in China, according to the latest data reported by the National Cancer Center, thyroid cancer has become the third common cancer in females. In 2015, the estimated number of new thyroid cancer cases was around 90,000. As far as I know, expected new cases in the United States in 2017 is about 57,000. So you see the difference between the numbers. When we look at the trend of incidence between 2000 and 2015 in China, the annual percentage change was around 20%. It increased rapidly only in women. Not surprisingly, in urban areas, incidence were much higher than in rural areas. Thyroid cancer was not in the list of top 10 high-death rate cancers in China. The mortality low level, but slightly elevated over the past 2 decades. The annual percentage change was 1.6%. The 5-year survival in China was 86% in urban areas and 79% in rural areas. The expected deaths in 2015 were 6,800. In the United States, the 5-year survival of thyroid cancer is 98%. You see 86 versus 98. China is still far behind of the United States. I also want to show you some real-world data from 2 big cancer centers in China. This slide shows the number of thyroid cancer surgeries per year in Tianjin Medical University Cancer Center. Tianjin is next to our capital city, Beijing. The hospital is one of the top 5 cancer centers in China. Between 2006 and 2016, thyroid cancer surgeries increased significantly. Among these cancers, small papillary thyroid cancer accounted for more than 50% of the cases. Another data is from Zhejiang Provincial Cancer Center. This hospital located in the southeast coast of China. The economy around this area is pretty good. According to the retrospective analysis, incidence of thyroid cancer grew quickly after 2007, mainly in urban females, with a rapid increasement of papillary thyroid cancer. Both micro-PTC and bigger PTC increased. Currently, micro-PTC accounts for more than half of all papillary thyroid cancers. So when taken together, the rapidly increasing incidence and the slightly increasing mortality of thyroid cancer in China, many people would think this phenomenon arises from overdiagnosis. Recently, a paper was published in Lancet Endocrinology and Metabolism, stating that in China, thyroid cancer overdiagnosis is a significant healthcare problem. In the figure shown here on the left, the dark blue bars represent overdiagnosed thyroid cancer cases, and the light blue bars represent not overdiagnosis. Though I would not deny that overdiagnosis exists in China, I discussed this result with some of my colleagues, and we were kind of surprised and confused by the high number of overdiagnosis. For example, this figure shows in Shanghai, total number of new cases per year is only 5,000. 85 of them are overdiagnosed cases, which means only 750 cases per year are clinically relevant thyroid cancer. It is hard to accept this concept because Shanghai has more than 20 million population and is the most developed city in China. It has been attracting a lot of people who seek good healthcare service from other regions. In addition, with the quick development in economy and healthcare system, now in China we have more hospitals, more hospital beds, more doctors, and more patients could afford seeing a doctor. Thus, we think it was likely thyroid cancer cases were misdiagnosed or underdiagnosed in the past, but in recent years have more chance to be diagnosed. We also should notice that over the past 20 years in China, so many things are changing. For example, climate, environment, lifestyle, obesity, etc. Accordingly, different voices on reasons other than overdiagnosis for causing the increasement of thyroid cancer everywhere in China. So given the fact shown in clear that screening thyroid cancer in general population may lead to significant overdiagnosis, in China, in the States, guidelines recommended against universal screening. In China, the guideline published in 2012 did not suggest or oppose screening, considering its potential benefit on mortality, cost, and negative impact, etc. However, here is the reality. So, especially in urban areas, many people ask for a check on their thyroid or include thyroid ultrasound in annual healthcare examination. Here are some reasons. More people are aware of thyroid cancer, and traditionally, cancer is a scary word. People are not convinced that cancers can be accurately classified into good cancer or bad cancer. People believe early diagnosis and early treatment of a cancer, no matter what kind of cancer it is, would be better. An ultrasound examination is easily reachable and affordable in China. Here in China, the average cost of an ultrasound is only $20. An ultrasound exam is usually listed in the options for annual medical checkup in many centers. So it is not surprising that the incidence of thyroid nodule thyroid cancer in China is growing faster than it is in the United States. Okay, now let's move to the next topic, evaluation of thyroid nodule. To my knowledge, in the United States, if you are found having a thyroid nodule, you need to make an appointment to see a doctor. Endocrinologists play an important role during the evaluation process. They will do physical examinations, ultrasound, TSH testing, sometimes fine needle biopsy, and molecular markers occasionally. All these steps aim to distinguish benign nodule and thyroid cancer. The evaluation process may be influenced by several factors such as availability of healthcare resources, insurance coverage, confidence in doctors, etc. In the United States, endocrinologists use ultrasound not only to look for worrisome sonographic features in the nodule and judge the cancer risk, but also to determine which nodule needs needle aspiration. A is commonly not used on a nodule smaller than 1 centimeter, unless there are some other clinical features, for example, suspicious cervical lymph nodes, young age, family history of clinical relevant thyroid cancer, radiation exposure during childhood. In the guidelines of ATA and the AACE, they recommend the risk stratification based on nodule sonographic pattern. They provide some pictures of this pattern. And 4 years ago, American College of Radiology proposed the ACR thyroid to do the sonographic risk evaluation for thyroid nodules and decide the size threshold for FNA. For nodule with indeterminate thyroidology, according to ATA's guidelines, after consideration of worrisome clinical and sonographic features, investigations such as repeat FNA or molecular testing may be used to supplement malignancy risk assessment. In the States, several molecular markers are available, including DNA markers, RNA markers, microRNA markers, and their combinations. Several studies have reported the clinical utility of these markers, suggesting molecular markers may be helpful to avoid unnecessary surgeries. I think it means a lot because surgeries are costly in the United States. Okay, now let's compare with the States. Let's say in China, some difference exists in the evaluation of thyroid nodule. I think one of the biggest differences is that surgeons instead of endocrinologists manage thyroid nodule predominantly. This is because traditionally Chinese people think nodules cancers are surgical conditions and should be evaluated and solved by surgeons. In addition, quite a number of Chinese doctors rely on ultrasound to evaluate thyroid nodules. I will get into more details later. And in general, in China, thyroid nodule can be tracked in many hospitals. Here, I would like to give you a glance of Chinese healthcare providers, which may probably help you to understand my comments later. So hospitals in China, as shown in this table, can be classified in three levels. Most hospitals provide service based on the first come, first serve rule. If a patient wants to see doctors in a tertiary hospital, they do not need a referral letter from GP or primary hospital. They can choose hospitals and doctors depending on their financial ability, as well as reputation and specialty of hospitals and doctors. Usually, tertiary hospitals have crowded patients, while primary hospitals don't. Because well-educated doctors prefer to work at tertiary hospitals and patients trust them more. Currently, hospitals of second level and third level perform thyroid nodule evaluation. As you may see in this table, endocrinologists and FNA are not available in every hospital. So many Chinese doctors rely on ultrasound much more than FNA to evaluate thyroid nodule. Experienced ultrasound radiologists are easily found in hospitals, but good cytologists are lacking in many places. Hello?
Yes.
Hi? Hello?
We can still hear you.
Can you speak? Oh, okay. So, first of all, ultrasound is considered more important than FNA in some places in China. The current Chinese guideline on the management of thyroid nodule was published 9 years ago and is under revision. In this 2012 guideline, thyroid function test and ultrasound were recommended as must-do items, but not like in the United States, The guidelines did not offer a figure or ultrasound patterns or thyroid categories to assist malignancy risk assessment. It only described some suspicious ultrasound features. So in practice, different thyroids were used by radiologists. In 2020, Chinese Society of Ultrasound Medicine hopes to uniform the thyroid imaging reporting system. They proposed a new system, Thyroid. They also suggested to FDA nodules larger than 5 millimeters with highly suspicious sonographic features. This is different from the recommendations given by the academic societies in the United States, because in the United States, usually nodule smaller than 1 centimeter, you do not biopsy. So given the fact that FDA was not available in many hospitals at that time, so this procedure was not always recommended in the 2012 guideline in China. As a result, although FDA is more and more accepted to be an important step, and amount of FDA is increasing in recent years, many nodules are still operated based on ultrasound without performing an FDA. And unfortunately, so far the thyroid has not been widely accepted by Chinese doctors. Here you can see many types of thyroids, including ACR thyroid, are used clinically by Chinese radiologists. Not all these thyroids speak the same. So in some hospitals, radiologists do not use thyroid at all. Therefore, it is not easy to communicate ultrasound findings among different hospitals. Another thing is most physicians and endocrinologists in China are not good at sonography. They do not have certificates to do ultrasound and know little about thyroid. Sometimes they are confused and misled by ultrasound reports. They may improperly suggest FNA or refer the patient to the surgeon. Synergistic use of cytology and molecular diagnostics for cell nodule is also a rapidly evolving area in China. Here, the most popular molecular marker is a BRAF mutation. As I said before, so good cytologists are lacking in many places. So the main purpose of using molecular diagnostics in China is to help confirming cell cancer and to facilitate the decision making between operation and observation. We now have molecular diagnostics options that are similar as GEC or cell-6 panels, but they are provided by cell tech technology companies. Most of them are not approved by CFDA. They are costly and seldom insurance covered. Lack of high-quality validation data and lack of experience with interpreting this data. So in China, I would suggest use them with very, very caution. So if the nodule is diagnosed as benign by cytology, in the States, guidelines recommend follow-up them using ultrasound. If the nodule has high suspicion, repeat ultrasound and ultrasound guide within 1 year. For the nodules with low or intermediate suspicion, follow up after 1 to 2 years. If the nodule has been biopsied twice as benign, repeat ultrasound is not indicated. For benign thyroid nodule, TSH suppression is not recommended. But in China, the guideline recommends follow-up using ultrasound every 6 to 12 months for benign thyroid nodule. The benign nodules here refers to cytologically confirmed benign or sonographic benign nodule. The guideline does not recommend the TSH suppression, iodine continuum food, or supplements, and Chinese traditional medicine. But it does mention that for selective nodules, radioiodine, percutaneous ethanol injection, and thermal ablation could be considered. In the guidelines, Surgery is recommended only for symptomatic and big thyroid nodules. But in some hospitals, especially low-level hospitals, the guideline is not followed well. Surgeons' preference and patient worries also greatly impact the decision of operation. Benign thyroid nodule used to be overtreated, especially in less developed areas. Situation is getting better in recent years through the continuous education. This is a systematic review that assesses the effect of Chinese herbal medicines in the treatment of benign thyroid nodules in adults. The authors drew the conclusion that firm evidence cannot be found support or refute the use of Chinese herbal medicine. And thermal ablation becomes more and more popular in China in recent years, including radio frequency, microwave, laser ablation, and HIFU. The majority of them are done by radiologists in China. Supporters like this therapy because it is a minimally invasive treatment, supported by European and Korean guidelines, similar cost but higher quality of life versus surgery. Patients like it because they want the nodules gone to end their worries, but they are afraid of scalpels. However, personally, I have kind of concerns that thermal ablation may be used too much in China. Their advantages are exaggerated by some radiologists. For vast majority of benign nodules, it is unnecessary to get rid of them. Overuse of this ablation therapy is not cost-effective at all. If the nodule is malignancy, what's the difference in the management between US and China? Here I try to list them. In the States, most carcinomas are known before surgery by FNA cytology. Microcarcinoma is now common as guidelines says no to FNA nodules less than 1 centimeter. In the operation, surgeons do not do prophylactic central neck dissection. Active surveillance of low-risk papillary macrocarcinoma has been supported by ATA's guidelines and implemented in some medical facilities such as Memorial Sloan Kettering Cancer Center. Post-operative management is determined based on TNM staging, risk stratification, and response to therapy. However, in China, as I mentioned before, not all patients go to surgery with FNA result. Intraoperative frozen section is usually done to diagnose bowel cancer and guide the surgery expert. For bowel cancer, our guidance routine prophylactic central neck dissection. Although an expert consensus published 5 years ago supports active surveillance for papillary macrocarcinoma less than 5 millimeter, it has not been widely followed because of concerns and controversies on this topic. Staging and risk stratification system used in the United States have been introduced to Chinese doctors and accepted by more and more doctors. It should be noticed that in China, not like in the United States, endocrinologists are less involved in the management of thyroid cancer. Instead, patients often go to surgery department even after surgery. Endocrinologists in China are not allowed to prescribe radioiodine. So radioiodine therapy can only be done in hospitals with qualified nuclear medicine physicians. Thermal ablation has been used for treatment of papillary macrocarcinoma in some hospitals, normally done by radiologists. Here is a multi-center prospective study to observe the initial management of patients with CTC in the real world in China. It started from 2014 and is still ongoing. This study enrolled more than 2,000 differentiated bowel cancer patients who were operated in 9 high-volume hospitals. Total thyroidectomy was performed in 83%. Central nerve dissection was done for almost everyone. 1/3 of them were prophylactic dissection. Only 9% of patients received post-operative radio iodine. I want to highlight two clinical pathological features among these patients. First, micro-PTC accounted for 52% of total cases. The second, 82% of patients were found nodule metastasis. 2/3 of them were undiagnosed prior to the operation. That's why Chinese surgeons insist to do prophylactic neck dissection. At 1 year follow-up, excellent response was seen in 31%, and indeterminate response was seen in 51% of these patients. Regarding surgery-related techniques, there has been a rapid progress in China, especially in tertiary hospitals in big cities. Endoscopic thyroidectomy, transoral thyroidectomy, and robotic thyroidectomy are all available in China in several centers. The map here shows numbers of transoral thyroidectomy done in medical centers across the world. China has the most centers where more than 100 transoral operations have been performed. In order to avoid surgical complications, intraoperative neural monitoring, carbon nanoparticles, and PTH test kits are used depending on doctor's preference and the patient's affordability. Compared to the United States, surgery cost in China is much lower. As for the management of low-risk pulmonary macrocarcinoma, active surveillance has been introduced by Japanese colleagues and officially recommended by Japanese guidelines. 5 years ago, Dr. Brito proposed that based on assessment on characteristics of tumor, patient, and the medical team, active surveillance can be performed in appropriate individuals. However, in China, active surveillance remains a very controversial topic. I did a survey among physicians and surgeons. 1/3 of surgeons and nearly half of physicians agree that micro-PTCs were overdiagnosed condition. 34% of surgeons and 40% of physicians agree that micro-PTCs were overtreated. Most of them were aware of data about active surveillance from Japan, but they found it difficult to change the tradition opinions about cancer, and their confidence in this strategy was not sufficient. In addition, many surgeons are afraid of medical disputes if progression happens during the surveillance, because they notice nodal metastases are very common in thyroid cancer. So it's not surprising that for the index case, who is a 65-year-old male and has a low-risk micro-PTC, less surgeons than physicians would prefer to do active surveillance. If potential medical disputes are not considered, additional 10% of surgeons would like to recommend active surveillance. In China, several centers have started their experience of using thermal ablation to treat micro-PTC. So far, published data suggested thermal ablation might be an effective and safe therapy for low-risk microcarcinoma. The therapy probably can relieve patient anxiety. However, thermal ablation are normally decided and performed by radiologists, not by multidisciplinary team. Besides, there has been no randomized clinical trials comparing outcomes from ablation versus active surveillance. It should also be noticed that when we do active surveillance on a papillary macrocarcinoma, we would know the macrocarcinoma progress when the tumor enlarges or presents nodal metastasis. Compared to nodal metastasis, tumor growth, I think, is easier to be found. Ablation ablation could destroy the tumor, but in that way, we may lose one indicator suggesting tumor progression. Therefore, before we get more convincing evidence for thermal ablation, academic societies in China recommend against using it routinely, expanding indications bluntly or saying leading words for ablations. These societies do recommend that thermal ablation must be done in qualified medical centers. They also encourage well-designed RCTs and emphasize all options for micro PTC be introduced to patients appropriately. So talking about radioiodine therapy in China, this therapy is given by nuclear medicine doctors. Early this year, Chinese Society of Nuclear Medicine updated its guideline on post-operative radioiodine therapy. Current indications for remnant ablation, adjuvant therapy, and treatment are listed in this slide. Normally, physicians use the fixed dose rather than calculated dose through dosimetry. Majority of breast cancer have indolent behaviors and favorable outcomes. There is a small proportion of patients have radioiodine refractory cell cancer, poorly differentiated cell cancer, or anaplastic cell cancer. They have a much worse prognosis. These advanced cell cancer patients may be eligible to systematic therapy. For patients with radioiodine refractory pathway cell cancer eligible for systematic therapy, two options are approved by both US FDA and CFDA. Both are oral kinase inhibitors, and both have been investigated in large randomized phase 3 trials, Precision study and Select study, respectively. In the States, FDA also approved a highly selective BRAF inhibitor, MERK inhibitor, and TRK inhibitor to treat eligible cases. But these medications have not been approved by CFDA. In China, systematic therapies are commonly prescribed by nuclear medicine doctors and surgeons in big cancer centers. These medications are relatively very expensive, and side effects may happen. For advanced medullary cell cancer, 4 options are available in the States: 2 kinase inhibitors and 2 recently developed highly selective RET inhibitors. In China, CFDA did not approve the 2 kinase inhibitors for medullary cell cancer. Early this year, a brown drug, anlotinib, developed by a Chinese pharmaceutical company, was approved by CFDA for medullary cell cancer. This is a kinase inhibitor. And another one highly selective RET inhibitor is available in China for lung cancer right now, and is very likely to get a medullary cell cancer indication by the end of this year. So in China, for better management of thyroid nodule and cell cancer, clinicians and researchers are making efforts. Academic organizations, they publish guidelines, consensus, statements, and textbooks. Working with Drs. Van Nostrand and Dr. Wojtacki, I translated their patient book into Chinese for educating both doctors and patients in China. Research papers on cell cancer from China keep increasing. So Chinese colleagues have done good jobs in artificial intelligence techniques for cell cancer and thyroid nodule. And also Chinese pharmaceutical companies developed new medications for advanced cell cancer and reported inspiring data. This is a recently published data. It shows the promising results of using anlotinib to treat medullary cell cancer from a randomized phase 2B trial. So in summary, it is clear that cell nodule and cell cancer in China are increasing, partially due to overdiagnosis. I think differences exist in the management of thyroid nodule and thyroid cancer between the United States and China. The precisely optimal management strategy for thyroid cancer remains unclear. So in China, agreements are not reached regarding whether or not to screen thyroid cancer, how to manage papillary microcarcinoma, indications for radioiodine therapy, etc. So in my opinion, shortfalls in the management of thyroid nodule and cancer in China include non-standard pre-operative evaluation. These differences in the management among areas, hospitals, and doctors, and the improper follow-up and lack of education. We do have achieved some advancements. For example, AI techniques for diagnosis of thyroid cancer, new medications for systematic therapies. I did not get into details about cost in my presentation today, as it is influenced by several factors such as individuals' preference, healthcare service, insurance, but the cost of operation in China is relatively actually is much lower than that in the United States. Before ending my presentation, I want to thank my mentors in China and in the United States. They guide me into the area of thyroidology, teach me a lot. Also, many thanks to my colleagues, collaborators, and fellows. Without them, I won't be here today. And thank you so much for your attention. And I'm very looking forward to your comments and questions.
Thank you, Dr. Guan, for that wonderful presentation, and it's really impressive some of the information you presented in regards to how the treatment changes and is influenced by the culture where it's practiced. I think is the example that you presented is a clear demonstration of that. One thing that it was very interesting to see is how the incidence of thyroid cancer is rising in China, and this rising thyroid cancer looks quite similar to what was seen in South Korea in the beginnings of 2000s, in the early 2000s, because similar to what you described in South Korea, there is also this the culture of more is better, as well as the screening is helpful. Do you think that some regions in China, some provinces in China, in regards to thyroid cancer, are going in the direction where South Korea went a few years ago? In other words, do you think that in next 10, 20 years, the diagnosis of thyroid cancer in China will look very similar to what's happening in South Korea?
So the question is, do I think the situation will be like in Korea several years ago about the screening thyroid cancer?
Yes.
I mean, okay, so I don't think they will be the same, because although in practically some doctors, they do screen thyroid nodule and thyroid cancers by ultrasound, but China is a huge landscape, and we have lots of population, so it's not like a universal screening. So I don't think the incidence of thyroid cancer will like in Korea will not be increasing that much, and in some urban areas, I think the screening will cause the increasement of incidence, but in the rural areas, actually, I think it's under-diagnosed problem. It's not over-diagnosed problem. That's my point.
No, that's great. There is a question from the audience, and the question says, in regards to the management after surgery, one thing you mentioned that after surgery, patients with thyroid cancer, everybody, or at least 93% of them, get TSH suppression therapy.
Surprising.
Yes, it is this to across the risk stratifications, meaning that low risk, intermediate risk, and high risk patients get the same suppression level, and also they get the same frequency of radioactive iodine treatment across the risk stratum?
Yes, right now more and more doctors, they will prescribe PSH suppression therapy and radioiodine therapy based on the risk stratifications. So one thing I need to point out here is PSH suppression is not always suppress PSH below the normal range. So relatively, PSH suppression is also included in this therapy. For example, for low-risk thyroid cancer, after surgery, the PSH level just can be suppressed down below 2 milliunits per liter. So it's not, the totally suppressed level. So we decide the PSH target based on the risk stratifications and risk of recurrence, etc. And also we decide whether to have a radioiodine also based on the risk stratification. But another thing may influence the use of radioiodine. The surgery, the total thyroidectomy or, lobectomy. If this patient was done with lobectomy, it's not possible for this patient to have radioiodine treatment. Also, you may notice in this cohort, half of them actually were microcarcinoma. So that's why only a small number of these patients received radioiodine after surgery.
I see. No, I see that. It is quite interesting too that the management of thyroid cancer has been centralized by the surgical group, because it seems to be that there are more surgeons available at the rural area than endocrinologists, for instance. That on top of that, the surgeons are more willing to do total thyroidectomies and central neck dissections. It makes me wonder what are the surgical risks in regards to the frequency of adverse events that you have probably seen over the last decade or two since the rising of this thyroid cancer.
I'm sorry, I lose your voice. So what's the question?
So yes, in short, the question is, have you seen more hypoparathyroidism and laryngeal nerve? Yes.
After surgery, right?
Yes.
So this is a very good question. Actually, when I prepared this presentation, I want to find some references from China to report post-operative complications. But it's very hard to find this kind of papers. I don't know the exact reason. Probably, in China, surgeons are afraid of those medical disputes, so they seldom report the complications after surgery. So I didn't find that too many references can provide these numbers.
I see. No, that is actually quite interesting. We have seen in other countries that the more thyroid cancer is found in a population, we start seeing the increasing surgical risk and surgical adverse events, such as laryngeal nerve injury, because of the people doing the surgery ended up being the people who have less experience performing surgery in the community. So it would be very interesting, to what extent to capture some of the downstream effect of overdiagnosis, and thinking about the surgeon, the experience of the surgeon, as well as the frequency of these adverse events. Very good. Again, Dr. Guan, thank you.
I know a paper will be published recently in JAMA Surgery. this work has been done by some surgeons in Guangzhou, in my city. So in paper, they talk about, lobectomy versus total thyroidectomy in terms of quality of life after surgery. So I guess from that paper, you may find some information about the complications after surgery. But right now, this paper has not been officially published, so I did not cite this paper. But I think this paper will provide information you probably are interested.
Yeah, I will look forward to reading that paper. Dr. Guan, thank you very much again for your fantastic presentation. It really gives us a very important insights about the differences in management of thyroid cancer, and hopefully we will have you again here in the future. I'd also like to invite the audience to attend our meeting next Friday. We will have another international perspective. For the next Friday, we will have doctors and surgeons from Colombia and from Brazil in regards to the management of active surveillance outside the United States, particularly in developing countries. With that, again, thank you, Dr. Guan, and thank you to the audience.
Thank you. Thank you for your attention. And thank you, Dr. Brito.